Thank you. Good morning. Thank you, Dr. Ajit Babu Maji, for giving this very kind and affectionate introduction. I don't know whether I deserve all these praises. It's indeed, I feel very humbled and honored to give this oration. Vasculitis is inflammation of the retinal vessels in the inner calciform layer of the retina. And periarteritis is the more common than periarteritis. And this disease, which you used to see quite frequently earlier, is the most common retinal vasculitis even today in India. Retinal vasculitis can be divided into the primary idiopathic ills, which is now no longer to be inflammation, ischemia, neovascularization, and cardiovascular proliferation. I like to talk about my work or my research in Lewis disease. In 1995, we asked the question, does Lewis disease occur in active systemic tuberculosis? I spent a year in tuberculosis research center in Madras, made a makeshift ophthalmology department, and examined 1,005 patients with active pulmonary and underlying encephalopathy TB in the TB hospital. Complete ophthalmic examination, including immediate ophthalmoscopy, was done. No case of Lewis disease was seen. This was quite surprising. But when you look, this was published in Ocular International Ophthalmology Journal, Ocular Morbidity in Patients with Active Systemic Tuberculosis in 1996. But when you look at the cohort of 29 patients of Lewis disease with a new examination technique, new imaging technique of the chest, high resolution computerized tomography of the chest, we found 15 out of the 29 cases, almost 50% patients had related tuberculosis. Chest sensitivity only 4 out of 29 cases. And this is what the picture of clean bud appearance of these disease patients having tuberculosis involvement. We looked at the histopathology and immunohistochemistry of Lewis disease specimens, and we did not only that, do the molecular biology study of the Lewis disease patients in 2021, which was published. This is a picture of the Lewis disease patients in the one eye, and you can see the capillary non-perfusion spheroid retinal vessel. And what is found in the illustrated blind eye or histopathology, multiple retinal blood vessels are surrounded by the lymphocytes. What were these lymphocytes? These lymphocytes are T cells, CD3 positive lymphocytes, and T suppressor cells in particular. And these cells are predominantly raised. And we found that the PCR for microvascular tuberculosis was positive both by and where by PCR, suggesting of tubercular etiology in these cases. If the microvascular tuberculosis DNA playing an important role in pathogenesis. We looked at the epithelial membrane in Lewis disease and other vascular retinopathies, and we found that epithelial membrane and the Lewis disease patients are surrounded by the blood vessel lymphocytes. And these lymphocytes are not seen in ventricular epithelial membrane in polycytic diabetic retinopathy. What are these lymphocytes? We did the immunophenotyping of the inflammatory infiltrate of the epithelial membrane and subretinal membrane in Lewis disease, and found there the predominantly pan-T cell marker showing in the bottom panel, and few of the pan-T cell marker positive. We concluded that AIOCMTC2 in Lewis disease is an immune-mediated process with predominant involvement of T lymphocytes. We looked at the improper expansion or expression of vascular endothelial growth factor and pigment epithelial derived growth factor in case of positive anti-downstream is variable in case of HLE. Prostate pancreatitis can be seen in various cases, like this we are reported in the patient at Rura in a young 8-year-old girl, and then recently we have reported in a 5-year-old boy who has prostate pancreatitis due to the extent by viral infection. You can see the extensive prostate pancreatitis and which responded with the steroid and antiviral medication. And the impact of prostate pancreatitis can be seen in the patient with abdominal tuberculosis. It is the biopsy-proven abdominal tuberculosis with the prostate pancreatitis with the tuberculosis, and it responded with the course of treatment with the ATP and steroid. Prostate pancreatitis can be seen in cytomegalovirus hepatitis in AIDS patients, as is seen in this picture. Extensive retinal vasculitis with retinitis, and this can also be seen in the symptoms of hernia, a non-infectious entity. What is concluded that the prostate pancreatitis is a sign only and can occur in various diseases. Retinal vasculitis can be associated with neurologic disease. This is recurrent anterior field retinal vasculitis associated with multiple sclerosis. Here we can see the MRI so the hyperintensification in the posterior limb of the internal capsule and corner areata, as well as the retinal vasculitis in the patient. Investigation, there is a risk of downstream workup can be done, but what we recommend is a tailored and focused downstream investigation, stepwise approach, and it is often non-contributed. Management of the retinal vasculitis infection the infection first, primarily associated with autoimmune disease system steroid in the first line of treatment, if not responding immunosuppressive or biology. And this is a case of retinal vasculitis in a patient who is multi-positive, multi-molecular positive, HSCT test positive, and it responded to the ATP and steroid immediately with complete resolution of the inflammation. In management of the inflammatory stages, we advocate treatment with the corticosteroids and ATP, neovascularization, laser resolution directly to the neovascular front or neovascular areas, neovascularization, which is several sections of the attachment typically without and laser. In basic disease is a kind of immunologic disease where immunosuppressive to the posture, cyclosporine or azathioprine can be used, and here is a patient who has treated the cyclosporine 1 week there is a significant resolution of inflammation, 3 months there is a complete resolution. In some way, biologics in retinal vasculitis is seen in the case of racist disease. This is one of the cases which we are used, and this is the immunobiology adenoma was used, and there is a complete resolution of inflammation. In conclusion, these diseases we consider now in the T-cell mediated immunologic reaction to the microphage process with DNA in a genetically predisposed patient. Ultra-white imaging is beneficial to document peripheral vascular changes in these diseases. Retinal vasculitis can be associated with various ocular and systemic diseases. Prostate pancreatitis is a sign only, not a separate disease. Management depends on the etiology of the retinal vasculitis. Systemic steroid works in majority of the cases. Immunosuppressive or biologics are beneficial in basic disease and HLE. With this, I like to thank you again for the honor, and I humbly accept this prestigious honor from the Autism Honor to the Retinal Lecture. I'm really fortunate, and I'm really more fortunate to talk on my experience with retinal vasculitis, which is close to my heart. Thank you once again for the wonderful opportunity.
The opportunity to hear from you the vast experience. Now I request Dr. Ajit Babu Garu to present a memento, sir, to Dr. Jyotirmay Vishwas Garu.
I think Santosh is engaged in the management committee meeting. Now we'll proceed to the next lecture. So this lecture, this is Rajesh Ganeshana's Innovations in Ophthalmology lecture. Now I invite Dr. Rohit Shetty to please come onto the dais. We identify audio please. Hello. Yeah. So every year we identify innovator anywhere in India. So and this year none other than our Rohit Shetty. I think he rightly fit into this criteria. And thank you very much, sir, for accepting and then coming here to deliver this lecture. To introduce Dr. Rohit Shetty is the cornea and refractive surgeon, and he was the consultant and cornea refractive surgeon and chairman of Narayan Nethralaya, Bangalore. And he is a clinical and a translation scientist, and he has several things. I think if I read it will be more than this lecture. Rohit actually doesn't need any introduction. So since he has the experience since last 15 years, he's completed his residency in St. John's Medical College and diploma in D&D, and then he obtained his FRCS Glasgow from Scotland, United Kingdom in 2006. He is currently an FRCS examiner. He is the chief mentor for the dual academic program at Narayan Nethralaya Institute at Bangalore and Massachusetts University. He was recently awarded Fellow of American College of Surgeons. He has several publications, and then he addressed almost all the major events in the national and the international level. With this introduction, I introduce Dr. Rohit Shetty to our audience. Now I request him to deliver this lecture.
This And these things Thank you.
Thank you, sir. Thank you for enlightening us with your innovations. And now I request Dr. Rajesh Garu to give a memento to Dr. Rohit Shetty Garu. The next APOS lecture is Pediatric Ophthalmology lecture by Dr. Vijayalakshmi Garu. I request Dr. Bharati Garu to take over and introduce Dr. Vijayalakshmi Garu.
Good morning, everyone.
And if you then include the last of this slide, you will
Thank you, madam, for your wonderful presentation, giving us insights. I request Dr. Bharati Garu to give a memento to Dr. Vijayalakshmi. Next session is Dr. O. Gopal Krishna's Young Ophthalmologist lecture by Dr. Sayan Basu Garu. I request Dr. Vishwamitra Garu to carry over.
I'm going to introduce you now to the audience. Just be seated in the Just మీరు ఏంటో ఈ ఆర్గనైజర్స్ అయినా అది పట్టుకొస్తారు చదువుతాను చదివితే స్టార్ట్ చేస్తారు ఇది ఎక్కడ పట్టుకొస్తారు ఇక్కడ పెట్టి Good morning, everyone. Please be with us. It's my pleasure to introduce Dr. Sayan Basu. I know him as a toddler, holding his hand, the hands of Dr. Virendra Sangwan in LVP, taking his baby steps, and now he became the director of the prestigious Professor Balasubramaniam Chair of Eye Research and director of Professor Brian Holden Eye Research Center and director of Center for Ocular Regeneration. Dr. Sayan, be ready. And he is the clinician scientist and a key opinion leader in the field of cornea and ocular surface, and is internationally recognized for his innovative breakthroughs in corneal stem cell therapy. In the clinic, his expertise in managing the complex and high-risk cases, particularly those with previously failed and complicated corneal and ocular surface surgeries. His specific research interests include dry eye disease, scarless corneal wound healing, and stem cell therapy, in collaboration with renowned national and international scientists. After completing his medical education from Archikar Medical College, he did his residency at Regional Institute of Ophthalmology, Kolkata. Dr. Basu did his long-term cornea and anterior segment fellowship at LBP Car Campus, Hyderabad, and subsequently joined the institute in 2010. He received his research training in stem cell biology from University of Pittsburgh School of Medicine in 2012 and 13. Dr. Basu has been honored with the Achievement Award from the American Academy of Ophthalmology and serves on the editorial board of several prestigious scientific journals such as Ocular Surface, IJO, BJO, etc. He has published more than 140 scientific papers which are highly cited. In his free time, Dr. Basu likes to be with his family, which is a rare opportunity, and read books and online pieces. His favorite authors are Ramachandra Guha, Siddhartha Mukherjee, etc. He is also interested in contemporary political history, including the Holocaust, the partition, the Cold War, and the emergency. I welcome Dr. Sayan Basu to be on the stage and give his star lecture of the day.
Thank you so much.
You'll be reminded 5 minutes ahead of your time. And
I am ahead or late? Is this on? Okay. So almost afternoon. So good morning. And I am very honored to be giving the Dr. Gopalakrishna lecture at the state meeting this year. And I want to thank the organizers and especially Madhu for the invitation and the honor. Extremely privileged. And thank you Vishwamitra for the very kind introduction. Dr. Gopalakrishna, as many of you may be aware, he hails from Vijayawada, which is in Andhra Pradesh. And he did his training from Kannur Medical College. He worked briefly at Arvind and also at L.V. Prasad and then various places internationally. He is very passionate about community ophthalmology, and he has a charitable trust where they do a lot of pre-cataract surgeries as well. And he is a very renowned and accomplished person in this part of the world, and I am very honored to be giving this eponymous lecture in his name. So I'll be talking about corneal regeneration. I'm a corneal transplant surgeon by training and also a clinician scientist. And I'll be taking you through the evolution of what we have done in corneal regeneration over the last 10 years or so, including stem cells, hydrogels, and 3D printed corneas. So this is the part of the eye that I work on, the ocular surface, which consists of the adnexa, the conjunctiva, the tear film, the limbus, the corneal epithelium, and the corneal stroma. So any disease that affects any part of the ocular surface comes under our domain, and we try to do the best in the possible situation. And this is where you can see that a large chunk and a very important part in terms of what vision the patient has is dependent on the cornea, and therefore diseases that affect the cornea and how we can treat them with regenerative therapies is of particular interest to me. We work with a very large group, so whatever I'm going to present, they are not my own accomplishments, but work that has been done by a very large group of clinicians, scientists, optometrists, engineers, and technicians, including clinical and research fellows who work in our group, which comprises of more than 40 individuals. And we are also very lucky and fortunate to be funded very generously from both governmental and non-governmental agencies, including many partners in the industry. So I'm going to first talk about the epithelium, corneal epithelial regeneration, and we are going to go layer by layer, but I'm mainly going to restrict myself to the epithelium and to the stroma. So the corneal epithelium, as you know, arises from the limbal stem cells, and our efforts have been towards regenerating a stable and a vascular corneal surface through epithelial regeneration. This is what a normal ocular surface with a normal epithelium looks like, and as you can see on the photographs on your right, this is the appearance of the palisades of Vogt, which contain the corneal limbal stem cells and maintain the corneal surface, and these are the hairpin loop vessels which are there normally in the limbus. This normal appearance of the limbus can be distorted due to a condition which is clinically called limbal stem cell deficiency. The photographs on the top panel are of cases of ocular burns, various degrees. If you go from left to right, you will see increasing severity of limbal stem cell deficiency because of burns. But burns are not the only cause of LSCD. It can also be due to allergy, as you can see on your bottom left. It can also be due to autoimmune diseases like pemphigoid or Stevens-Johnson syndrome. There are many ways of diagnosing this condition, and confocal microscopy and impression cytology play an important role, but they are mostly relevant for research. What we have found is that for limbal stem cell deficiency, a simple OCT line scan is actually most accurate, and it gives you a lot of information. If you have access to angiography, that also helps. But a simple line scan will tell you that limbal stem cell deficiency, you have abnormal epithelium, which is hyperreflective, over a hyporeflective stroma, which is exactly the reverse as you see in other corneal conditions where the epithelium is normal, but the disease is in the stroma. For a long time, we were treating limbal stem cell deficiency with ex vivo cultivation, or a technique called cultivated limbal epithelial transplantation, which used to give very good results. But in about 2010, we shifted to this technique of simple limbal epithelial transplantation, which maybe many of you in the audience may also be performing for the treatment of LSCD, and this really revolutionized the way that we were treating patients with limbal stem cell deficiency, particularly to ocular burns. It's a very, as the name suggests, simple technique, a very simple approach. You remove the pathological tissue from over the cornea and you replace it with small bits of normal limbus which are taken from the healthy eye, and this leads to regeneration of the ocular surface almost magically, as you can see in this photograph. And how this works is that, as you can see from this fluorescent stain photograph, these tiny bits of limbal tissue, they lead to regeneration of the epithelium, and you can see from the negative staining islands of epithelium arising from these tiny bits, which then join with each other to form large sheets, and this leads to the epithelialization of the entire surface. So this is typically how you can have an eye which is completely scarred and vascularized because of limbal stem cell deficiency with conjunctiva growing over them on your left, slowly transform into an absolutely clear corneal surface with a normal avascular epithelium in a few months, and can sustain itself over many years because of simple limbal epithelial transplantation. So these are typically cases that we treat with SLET. This is how the eye looks preoperatively, completely covered with vascular tissue, with symblepharon, etc. And this is the same eye after surgery post-SLET. The recovery usually happens with clearing of the cornea, and sometimes there is clearing of the corneal stroma as well over time. So not only is there some amount of epithelial regeneration in these cases, but there is recovery of stromal clarity as well. And this is the same case that I showed you before, and this is the post-operative outcome after SLET, where you can see that all the vascularization and the scarring from the corneal surface is gone, and you have restoration of a clear surface, and obviously these patients recover very good vision. We have been teaching SLET over the last many years to hundreds of surgeons in India and across the world, and now we have enough evidence from across the world to show that these results are not just what we show in our hands, but they are very replicable, and people who learn this technique are able to replicate the results just as well as those who are very experienced in them. And the overall success rates, which are very satisfying and gratifying to see, that have been replicated by multiple studies across the world, even multicentric studies which have looked at the success rates. And currently the success rate of this procedure for cases of limbal stem cell deficiency are above 90%. You have to remember that limbal stem cell deficiency only a few decades ago was completely untreatable. It would not respond to corneal transplantation. And we have developed this technique which not only gives clinically successful outcomes, but also shows preservation of stem cells, and as compared to other techniques of limbal stem cell transplantation, has shown to be good, if not better, in terms of both anatomical and functional outcomes. With this success in epithelial regeneration with SLET, we wanted to replicate the same for stromal regeneration as well. Stromal regeneration is a little bit more complex than epithelial regeneration, and the reason that we wanted to focus on this is for the very peculiar reason that in India, corneal blindness is mostly due to stromal opacification because of the high incidence of infection and trauma in our country and also in the rest of the developing world. Unfortunately, most cases that have corneal opacification because of injury and trauma also carry a very poor prognosis for corneal transplantation. So most of these cases actually are not amenable to corneal transplantation, and therefore we need to look for other options. Otherwise, if we just try to address corneal blindness in India with corneal transplantation alone, we will end up in a few years with more and more failed grafts than anything else. The stroma, however, is remarkably simple. You have extracellular matrix, which is basically a collagen network with proteoglycans, and you have keratocytes, which are the cells that produce this extracellular matrix. And the corneal stroma together is nothing but a combination of the keratocytes and the extracellular matrix. So if you're going to regenerate stroma, you have to find a way in which you can create keratocytes. You also have to find a way in which you can create the extracellular matrix, and then maybe you can put these two together. It's also important that we have a reliable way of measuring scarring, because that is not something that we do routinely in our clinics. And we used a protocol where you have a combination of imaging devices to define what a scar is. And this is also very interesting, because normally when we look at a corneal scar, we only focus on the opacification in the corneal stroma. But actually a corneal scar is more than just the opacity, because you also have an element of thinning, because most of these scars are post-trauma or post-infection. There is also a flattening of the surface, and there is an irregularity that is caused in the surface as well. So when you regenerate the corneal stroma and you treat a corneal scar and opacity, it is not enough just to render the stroma transparent. It is also important to address all the other elements of this pathology, which includes the thinning, the flattening, and the irregularity. So we have to not only remove the opacity, but also improve the regularity of the cornea, regularize it, and also increase the thickness to a certain extent. Only then and only then will the patient's vision improve. It will not just improve with removal of the opacity. The case in point, keratoconus, where you have a relatively clear cornea, but because of the irregularity of the cornea, the patient is not able to see it clearly. So the first thing that we did was to establish an animal model where we could create scars and then try our therapeutics to see which one was working best, and then to make this model very reliable and comparable to what we were seeing in the clinic. So created a system where in vivo we could measure the scar, and we could assess that the quality of the scar that we were producing in the animal model was similar to what we were seeing in patients. So after working on the animal model, we start started first to work on the cells or the keratocytes. Now this is an idea that is borrowed from my mentor Jim Funderburg's lab in Pittsburgh in the United States, where they found stromal stem cells or mesenchymal stem cells in the limbal stroma, very close to where the limbal epithelial stem cells lie. And they showed in these initial studies that you could take these stem cells and they would help in regenerating corneal opacities in congenital opacities. And when I worked with him, I worked on traumatic opacities as well and showed that these cells were effective. So over the last 6-7 years or so, we have been working with the regulatory agencies in India and doing clinical trials using these stem cells from the limbal stroma for the purpose of treating corneal opacities, burns and infections. So this is what we do. We take corneoscleral limbs from the eye bank, and these are cut into small pieces which are digested. And at our GMP facility at LVPI, these are then incubated and grown. And when these cells grow out, you get a mixture of epithelial and mesenchymal cells. And you can see that these cells are growing in these culture plates. And then after serially passaging them or just reculturing them over and over again, you can get a pure population of mesenchymal cells which are then transported to my operating room for transplantation. Like SLET, the technique or the delivery of the stem cells in stromal opacity treatment also is remarkably simple, where the cells are mixed with one of the components of commercially available fibrin glue. The epithelium is removed gently with a sponge, and then a drop of that glue is placed on the opacity or whatever is the pathology in the stroma that you're trying to teach, and then it is layered with the other component of the glue. This creates a sandwich which is sticky, which gelates on the surface, and this is a completely sutureless technique that we are using here. As you can see, this is being done under topical anesthesia, and this is basically the intervention that we have done in the 2 clinical trials that we have run with DCGI approval. And after you have put the required dose of the cells with the glue, just a bandage contact lens. These patients receive nothing but topical antibiotics for the first post-operative week, no corticosteroids, and we see extremely gratifying outcomes when we treat formed scars, and even better outcomes when we treat ocular surface diseases which have acute inflammation. So these cells, the mesenchymal cells, are anti-inflammatory in nature, and they can modulate the corneal stroma to get rid of the opacification of the scarring. As you can see in these panels photographed from the left to the right, where you have a scar in the visual axis, and 3 months down the line, the scar has either visibly reduced or completely disappeared. So these are patients that we are following up right now. We have just completed 1 year of the follow-up period, and we have found that these results are very consistent over a long period of time. And there may be a case where repeated treatment may be required, but what we have seen is that even a single treatment can result in not just amelioration of the opacity, but also regularization of the corneal surface with this therapy. And the final frontier for us is the extracellular matrix or the rest of the corneal stroma. And this is also something that we have been working on. We have 2 approaches. One is creating a corneal hydrogel, which basically is taken or made out of the discarded corneas from the eye banks. As you know, 40 to 50% of corneas that are collected for transplantation are not suitable because they are not optical grade and they are discarded from eye banks. So we collect these corneas, we grind those corneas into a powder and make a hydrogel out of it. So basically it's like a gel that you can use as a sticky applicant on the patient's cornea directly. This can be used when there is direct trauma to the eye. So the patient comes with a corneal laceration, corneal tear, or an ulceration, and you can just stick it on the corneal stroma. And you can also use this as a bioink to print different kind of stromal lenticules, and which I will be showing you next. So initially we tried many different sources, but we figured out that the human source is the best because that is the native tissue, and this can really help in amelioration of wound healing in a way that it switches from repair to regeneration, which means that if you apply it to a corneal wound, instead of it causing a scar, healing with scarring, it will heal with normal tissue where there is no scarring and the corneal stroma remains transparent. So we have completed the animal studies with the hydrogel, where we have shown that application of the hydrogel in these traumatized corneas does not lead to scarring, but leads to maintenance of a stable and transparent stroma. And in our final pursuit of the entire corneal stromal matrix, we are using the same hydrogel to print cornea. So this is As you can see in this video, what is known as a 3D printer, but the same hydrogel is used as a bio-ink. And using different molds, which are of different shapes and sizes, you can actually print corneal tissue. And as you can see on the top right photograph, that is what the printed corneal tissue looks like. It looks exactly similar to what a normal corneal tissue looks like. And therefore, where you do not have access to a donor for a cornea, you can actually in the very near future use lenticules which are customized to the shape and size that you require. The first 3D printed cornea is what we made from this, and this is our latest version of our 3D printed cornea that we are using, where you can see that we are able to even pass sutures and tie them and suture them just like a normal cornea. This is not a corneal tissue that has come from the eye bank. This is a corneal tissue that has been made in our laboratory. So we want to address stromal blindness as well, in addition to epithelial blindness, because it is more common, it is more complicated, and the outcomes of corneal transplantation are not that great, and therefore we are looking at these options of keratocytes as well as 3D printed cornea. So in the short term, we are looking at the safety and efficacy profile of the individual and combined products. In the long term, and this is around the corner, in the very near future, you will have cell therapy for corneal and ocular surface inflammation, which is just using the stem cells and applying them with glue or injecting them on the ocular surface or into the eye. You will also have hydrogels for corneal wound healing, where you will be able to use them just like a glue patch to seal perforations, to treat wounds, lacerations, and you will also have customized 3D printed lenticules not only for transplantation but possibly also for refractive correction and refractive surgery. Thank you so much for your attention. Good? No, it's fine. Thank you so much, Vishwa. Thank you so much.
Thank you, Bas. And personally, my request is, as you know, that keratoplasty is taking tissues from the donors, etc., is not that good or something. So I wish you become successful in regenerating all epithelium, stroma, and endothelium, etc., and you come up with that fully regenerated entire cornea.
Someday that will happen, but I think that what we are trying to do is not to make the eye bank redundant, but
No,
to make the eye bank expand.
don't worry about the eye banks, because taking tissues from somebody, donors, or this is much more better than this one. I wish you success in future.
Thank you so much.